The topic given to me, I was asked to talk about perioperative nutrition in a surgical patient and the non-GI surgery patients. Obviously, patients who are undergoing surgery on the gastrointestinal tract, they have a whole lot of additional challenges relating nutrition in perioperative and especially post-operative period, and those would have to be taken separately and in a more focused way, which I am sure Professor Rajan Saxena and his team will take care. But I will be addressing more general principles of nutrition in a patient who's undergoing surgery. So essentially, my talk would limit to principles of the nutritional support in a patient undergoing non-gastrointestinal surgery. These patients would have either enteral or parenteral nutrition, and often a combination of the two in the perioperative period. Uh, so there are two very distinct um, schools of thought today while taking care of patients who are undergoing surgery. The conventional method of managing patients as far as their fluid, electrolytes, and nutrition are concerned, and the newer, the ERAS protocols. So I would like to discuss both of them and emphasize more on the ERAS protocols, which are really beneficial to not just the patient but the healthcare systems as well, to the hospitals, to surgeons and teams. And even if you do not follow the complete ERAS protocols, quite a few of those concepts have been adopted by almost the entire world, which initiated as part of the ERAS protocols, but now we practice them as a routine. There are certain specific nutritional issues in patients undergoing surgery, and these include, besides the calorie, the protein, and essential fatty acids, micronutrients, and some concepts about immunonutrients. So let's see what all we can cover in this 30 to 40 minutes time. So, what are the goals of nutritional support in a patient undergoing surgery? These goals include prevention and reversal of the catabolic effect of the disease itself. And if we include patients who have trauma, who have injuries or accidents, the catabolic effect of of the trauma itself. The other goals include the need for meeting the energy requirement of a patient undergoing surgery. The metabolic processes in surgical patients are often deranged, and majority of patients are in a hypermetabolic state, especially in the early postoperative period. And in case they have some complications or sequel of the surgery itself or anesthesia, then of course this hypermetabolic state and state of stress may prolong, and then these require specific attention as far as nutrition is concerned. We also need to make sure that the core body temperature is maintained in a normal range, and we also need to provide sufficient substrates for the tissue repair and healing. Mind you, while doing surgery, you are creating wounds, you're creating controlled surgical wounds which require substantial substrate amounts for healing and repair. So an essential step in nutritional assessment of patient is to assess the energy requirement of a patient. This is performed in the preoperative assessment during the preoperative assessment of the patient, and it includes various parameters, including various factors which emerge out of the history, the physical examination, patient's body weight, and the BMI, as well as by way of some biochemical assessment, including the serum albumin levels, blood counts, creatinine excretion, serum transferrin, etc. And all these put together give us an assessment of the patient's nutritional status and the requirements you would expect in this patient in the perioperative period. How do we assess the calorie requirement? There may be many ways, but one of the commoner method utilized is the use of the by calculating the resting energy expenditure, or the REE. And then this is done by using the Harris-Benedict equation, which utilizes various variables, including the gender, the weight of the patient, height, and the age. And the formulae are very different for men and women, essentially to take care of the specific needs of an individual. And the calorie requirements based on the, oops, there is some disturbance. Oh, who's in the traffic? We can hear quite a bit of traffic noises. Can you please, Anupam Agrawal, can you please mute yourself? Yeah, thank you. Okay, excellent. So the calorie requirements are then calculated by multiplying the basal or the resting energy expenditure by the activity factor and the stress factors. And these are all factors or formulae available widely in the literature. There are other ways of assessing the calorie requirement. These include indirect calorimetry, where the resting energy expenditure is calculated in terms of as a factor of the patient's VO2, which is estimated in milliliter per minute. And then we can also use the DEXA, the dual energy X-ray absorptiometry method, which measures the lean body mass, the fat mass, and the bone density. Uh, there are essential requirements of electrolytes in the perioperative period, and these daily requirements are important determinants or are important things to remember and use during the perioperative period. Sodium, potassium, magnesium, calcium, phosphorus, all these have to be provided adequately, either in the enteral or parenteral nutrition. There are a number of micronutrients too, and this list, though quite a long one, may still not be a complete one. And every passing year, we are told, or new emphasis is laid on newer micronutrients: iron, zinc, copper, chromium, selenium, manganese, the various vitamins, vitamin E, A, C, D, K, and then other micronutrients like thiamine, riboflavin, niacin, pantothenate, pyridoxine, folic acid, BIZ, and biotin. All these. This is just one list, and I'm certain in the course of this 02 course, you would learn much more about these micronutrients. So I would just like to reiterate that it's important that we keep all these factors in mind while chalking out or planning the perioperative nutritional plan for the patient, and don't miss out on the micronutrients. So the principle that guide the post-op nutrition, of course, this was all the pre-op assessment of a patient's nutritional status, but having operated the patient in the post-operative period, there are certain important determinants of what nature of nutritional practices you would utilize in a given patient. So the guiding principles are that if the GIT is functional or fully functional, that is to say, the patient is not in ileus, patient is not vomiting, and or such a procedure has not been performed, which precludes use of the GIT, then the oral route must be utilized. Or in other words, patient must be fed orally unless there are contraindications. One should initiate the enteral nutrition in a patient who's expected to be on full oral diet within 7 days post-operatively and has no GI contraindications to enteral nutrition. If, however, enteral there is a contraindication or numerous contraindications to use of the enteral route, or if the enteral nutrition is not tolerated by the patient, then a parenteral route can be utilized. Then parenteral nutrition can be initiated within 24 to 48 hours of the surgery and not delayed beyond 48 hours. Who are in such patients who are expected to be able to tolerate full enteral nutrition within 7 days. Uh, Another important principle to remember is that we must administer at least 20% of the calorific the calorie and protein requirements enterally while reaching the required goal with additional parenteral nutrition. Maintenance parenteral nutrition is essential until the patient is able to tolerate 75% of calories through the enteral route, and then enteral nutrition can be initiated until the patient is able to tolerate 75% of calorie via the oral route. So these are some general principles we keep in mind. And as I said in the very beginning, I would be mostly concentrating on patients who did not undergo a GIT surgical procedure and had, say, peripheral or a limb surgery or a superficial surgery, which does not preclude patient from taking oral diets or enteral nutrition. The details of parental nutrition and then nutrition in a GI case would all be taken care in a separate lecture in this course. So these are some of the contraindications to enteral nutrition, which I'm certain all residents, all of you who are working in various clinical fields would be very clearly, we would be quite well aware of. If the patient has intractable vomiting or diarrhea, which is refractory to medical management, or if the patient is in ileus, paralytic ileus, then of course you would not be able to give the patient enteral nutrition. If the patient has a high output intestinal fistula, too high or too distal to bypass with the feeding tube, then of course this is a contraindication to enteral nutrition. Intestinal obstruction, ischemia, diffuse peritonitis, severe shock, or a patient who's hemodynamically unstable. These are conditions where you would not be able to initiate enteral nutrition. Patients having GI hemorrhage, severe short bowel syndrome, severe GI malabsorption syndromes, for example, uh, post surgery. And then these other examples of such malabsorption conditions are enteral nutrition failure, as may be evident by progressive deterioration in nutritional status even after initiation of enteral nutrition, and inability to gain access to the GI tract, which can occur at times. Uh, if these are present, or else we expect that these would not be taken care within a span of 7 days, then of course parental nutrition would be required. This kind of flow chart or algorithm, I'm certain most of you would be following some similar form of algorithms for providing nutritional support to perioperative patients. So the assessment should be initiated to identify what kind of nutritional support an individual patient would require. If there are no contraindications to enteral nutrition, then of course enteral nutrition is what you initiate. If patients require long-term enteral nutrition, then you may require gastrostomy or jejunostomy. However, if there's only a short-term enteral nutrition requirement, then you may simply use a nasogastric or nasojejunal or nasojejunal tubes. And then subsequently, depending on the GI function, if it is normal, the standard formula enteral nutrition can be given. If, however, GI functions are compromised, then the patients would require specialized formulae, and again, depending on does the patient tolerate the standard or specialized formula enteral nutrition. If the patient has adequate tolerance, then one can advance to oral feeding. If the patient has inadequate tolerance, then supplementation with parenteral nutrition may be required, and then if so required, then progression on to total parenteral nutrition as well. If patient's GI function is compromised and the patient can be adequately nourished with specialized formulae, then one can consider oral feeding. The other side of this whole algorithm is patients where there are contraindications to enteral nutrition, which would mean that the patient requires parenteral nutrition, either supplemental or total parenteral nutrition. If there's a need only for a short duration, anticipated need is for a short duration, then one may not resort to a central access, and this can be done through a peripheral line or peripheral parenteral nutrition. If, however, you anticipate that the parental nutrition may be required for long term, then of course a central line of central parental nutrition should be resorted to. And as soon as there are signs of return of GI function and the contraindications to enteral nutrition are reversed, then patient should be switched on to enteral nutrition and then subsequently to oral intakes. Otherwise, if in case this is not possible, then of course long-term parental nutrition will have to be continued. So the various routes of enteral nutrition, of course, if just to be clear about this, so the preferred route is to resume oral diets as soon as possible. However, there would be patients who may not be able to either take oral diets or tolerate oral diets, and in which case we may have to resort to one or the other form of enteral nutrition. The various routes of administration of enteral nutrition may be nasogastric, nasoduodenal, nasojejunal, or a gastrostomy or a jejunostomy, which can be done either percutaneous or endoscopically or radiologically, interventional radiologically. The advantage of enteral nutrition are that you will be able to provide trophic feeding. We can maintain structural and functional support of intestinal mucosa by providing the various micronutrients, glutamine, preserving blood supply and promoting peristalsis. The another advantage is that we can maintain the integrity of intestinal mucosa, preventing bacterial translocation and loss of the useful bacterial flora. And besides, enteral nutrition is relatively cheaper and easier to administer and safer as compared to parental nutrition. Total parental nutrition is where you would use intravenous infusion of nutrients in elemental form. As I said earlier, it would be either peripheral or central total parental nutrition. It comes at a high cost and has many possible complications which limit the use of total parental nutrition. However, it becomes essential in patients with contraindication to oral and enteral feeding. This is essential that a patient should be hemodynamically stable for TPN usage. Of course, there are some exceptions where we have to use TPN even in patients who are hemodynamically unstable, but these are fortunately few. And as I have been maintaining during the talk, the details of these total parental nutrition and even enteral nutrition would be covered in another talk in this course. So these are some of the conditions which require careful use of TPN in patients who are hyperglycemic, azotemic, those who have hyperosmolality conditions, hypernatremia, hypokalemia, hypochloremic metabolic acidosis, hypophosphatemia, hypochloremic metabolic alkalosis. So these are all conditions which require careful TPN usage. Now, switching gears, let me quickly talk, or in short, talk about this concept of immunonutrition. Now, this is to some extent a concept which is still in the realms of research. However, these days, at least some part of these concepts are being used routinely with obvious benefits to the patients. These are nutrients which affect the immune system, and there are a number of them recognized, including arginine, glutamine, omega-3 fatty acids, and nucleotides. There are certain other potential immunonutrients. These include vitamin C and E, selenium, copper, zinc, taurine, branched chain amino acids, and acetylcysteine. And whether these are useful or not is still a matter of debate. Arginine, a well recognized immunonutrient, it's a semi essential amino acid. Uh, there is a relative deficiency of arginine which exists in metabolic stress states. The metabolic role of arginine is in the collagen synthesis. It's a secretagogue for insulin, prolactin, growth hormone, and it's a donor of nitric oxide. It counteracts the myeloid suppressor cells along with omega-3 fatty acids. The zeta chain in T cell receptor complex is arginine sensitive, and there is quite a good evidence base that arginine has a role in patients being treated for extensive burns. It has a pro-inflammatory role, and this might be counterproductive in patient with sepsis. And usually the dosage used is 12 grams per 1,000 calories administered to the patients. Glutamine is another semi-essential amino acid. It's a fuel for the enterocytes, colonocytes, lymphocytes. The components of it's a essential component of glutathione, which is a precursor of nucleotide synthesis and neoglucogenesis. It is helpful in synthesis of mucin protecting gut mucosa and results in down regulation of toll-like receptor, thus reducing inflammatory cytokines. It has a significant proven benefit in patients with burns. Early studies have shown beneficial effects in critically ill patients. Uh, it is unstable in solution, so it's packed in dipeptide form or powder or granule form. This needs to be reconstituted before administration, and it can be administered enterally or parenterally, and the doses for the two are different and are written here. Omega-3 fatty acids, these are number of fatty acids: alpha-linoleic acid, eicosapetanoic acid, and docosahexaenoic acid. Uh, we know there is quite a bit of evidence that omega-3 fatty acids have anti-inflammatory effects. This is contrary, or this is very in stark contrast to omega-6 fatty acids, which have pro-inflammatory effects. The various anti-inflammatory effects of omega-3 fatty acids include displacement of arachidonic acid from membranous phospholipids, inhibition of conversion of linoleic to arachidonic acid, activation of peroxisomal receptors, stabilization of NF-kappa B, beta, and suppression of pro-inflammatory genes. It also reduces expression of ICAM1 and E selectins. It stabilizes the myocardium, reduces dysarrhythmias, and reduces the risk of ARDS in critically ill patients. Nucleotides are other not so clearly, not so evident, or are established immunonutrients. However, these are essential for DNA and RNA synthesis and for proliferation and a normal functioning of phagocytes. Nucleotides also protect the gut from mucosal atrophy, and these are part of most of the standard enteral and parenteral nutrition. These are lacking in majority of the enteral and parenteral nutritional formulae, and so need to be remembered specifically. Now, let me, in the remaining part of this talk, uh, provide you some information about the nutritional considerations in ERAS. Now, all surgical teams or people who are in the surgical practice or in practice of interventional medicine and the anesthesiologist cannot um, practice without adequate exposure to the ERAS concept. What is ERAS? Enhanced Recovery After Surgery. This is a whole set of clinical pathways which have been developed to accelerate recovery following surgery and interventions. These were initiated in 1990s, initially for the elective colonic surgery in adult patients undergoing colonic surgery. These utilize multimodal, multidisciplinary concepts and interventions to improve the outcomes of patients undergoing surgery and hasten their recovery, enhance their recovery. The principles utilized are to avoid any condition or anything which increases the starvation or stress, and optimization of the pain control, GI function, and mobilization or early mobilization of the patients. So this concept utilizes an assessment done at least 10 days preoperatively, and then so that the few things which may be deficient can be replenished, plus provide supplemental diets to reduce the perioperative nutritional deprivement. 1 day prior to surgery, the patient is administered a whole set of nutritional supplements, and then on day of surgery and immediate post-op period, patient is advised nutritional supplements and discharged on the same. The principles which we use in ERAS, they essentially reduce insulin resistance and promote anabolism, uh, which is to counter the catabolic state that surgery and anesthesia can bring in. Uh, why do we bother so much about insulin resistance? We know that hyperglycemia, which is a result of a stress of the surgery and anesthesia, is pro-inflammatory. Hyperglycemia is indicative of or it predisposes to inflammation, which further increases the insulin resistance and which can trigger a number of or a cascade of complications. In patients who have insulin resistance, or sorry, in patients who have undergone major surgery, there are studies which have documented evidence of insulin resistance in up to 50% of patients. And these patients who have insulin resistance, they have five-fold greater chances of complications or perioperative complications, and they are at a tenfold increased risk of infections. So, if we can uh, prevent the initiation of this pathway of hyperglycemia, insulin resistance, and complications, or arrest this progression from hyperglycemia to insulin resistance, we will be able to prevent or manage complications better. In the peroperative period, immediate preoperatively and then postoperatively, in the ERAS concept, nutritional considerations are important. The various components to these are to avoid preoperative fasting, to avoid full bowel preparation, and provide for adequate perioperative nutrition. The whole ERAS perioperative program includes these various components: counseling of the patient, avoiding bowel preparation, loading the patient with sufficient fluids and carbohydrates before surgery, no or as little fasting as may be possible, no nasogastric tubes, epidural pain control, short-acting pain medications, DVT prophylaxis, perioperative nutrition, non-opiate analgesics, avoidance of sodium overload, maintaining normothermia at all times, early mobilization of the patient, nausea and vomiting prevention, stimulation of the gut, early removal of any of the tubes, and perioperative antibiotics. But as you would understand, as you would appreciate, a lot of these are nothing but nutritional concepts which are put into use in a way that the patient has early and enhanced recovery. So there have been number of studies which have documented no a, a need for uh, an NPO status after midnight to avoid aspiration. For ages, we surgeons and anesthesiologists have been practicing NPOs after 10 p.m. or midnight to prevent aspiration. However, a Cochrane review as well as numerous other studies have documented that irrespective whether the patient was put on overnight fasting or NPO versus early morning NPO, uh, the patient did not have aspirations in majority. Uh, Clear fluids can be allowed up to 2 hours prior to surgery, and solids can be allowed up to 6 hours prior to surgery. Uh, in the ERAS protocols, there's a clear advice to give clear carbohydrate-rich beverages, which can be given up to 900 cc at midnight and 400 cc 2 hours before surgery. And these provide up to 400 kilocalories in the midnight and 200 kilocalories early morning. And these reduce perioperative thirst, hunger, anxiety, and do not allow insulin resistance to trigger in. And as I had explained to you, it's insulin resistance which triggers the whole cascade, leading to inflammation and more complications perioperatively. What is the evidence that this works? There's a whole Cochrane review of 22 randomized controlled trials, which have very clearly documented that by using such an ERAS protocol, there's no increase in complications in these patients, in perioperative patients. These patients who had undergone the ERAS protocol or where ERAS protocols were used, they had similar gastric emptying as compared to conventional protocols. Even in patients who were obese or even morbidly obese, uncomplicated type 2 diabetes, and those who were lean, all of them had similar gastric emptying. In post-operative period, very early in post-op, as soon as possible or 4 hours post-op, oral nutritional supplements are added, and these include 400 to 600 ml per day of energy dense fluids, and these are, and plus continue the oral supplements for 3 weeks post-operatively. And this is something very starkly different from the conventional protocols. These are expected to maintain the nitrogen equilibrium and also prevent hyperglycemia in this post-operative period. Hyperglycemia, mind you, is the one which triggers insulin resistance and then pro-inflammatory condition and leading to complications. So this was all that I had to talk about as far as ERAS concept is concerned, and the uh, nutritional concepts which are utilized as part of the ERAS protocols. As I said earlier, some of these concepts which are utilized in the ERAS may not be universally practiced, but quite a few of those concepts have actually been universally adopted. There's whole set of there are various organizations and bodies which have provided guidelines, and for example the SPEN guidelines, which are very commonly utilized. Similarly, the North American Surgical Nutritional Guidelines, which were a result of a summit done in 2013, have utilized very similar concepts which are part of the ERAS protocols too. What do these guidelines provide or advise? They denote a paradigm shift to the concept of prehabilitation rather than rehabilitation. The approach is multidisciplinary, where diet, mobility, volume, temperature, uh, through the post-op period are thought about and practiced. Preoperatively, the patient's nutritional assessment is important, and it depends on the type of surgery. The NRS 2000 score of more than 5, HbA1c of less than 7.5 to achieve weight loss with BMI of more than 35, if these patients, if it is possible to achieve weight loss, and it is desirable if the patient can achieve 5 to 10% weight loss over 1 to 3 months in patients require undergoing an elective surgery which can wait for that time period. Other things that this summit and these guidelines provide for are the preoperative nutrition, where careful assessment and provision for immunonutrition are given, which are started 5+ days preoperatively. Enteral nutrition is preferred over parenteral nutrition. Parenteral nutrition is reserved only if the enteral is not possible. It advises to hold soy-based lipids post-operatively in the post-operative within 24 hours post-operative period. Resuscitation improves the post-op feeding, and it says that the basic barriers to starting early feeding are we surgeons and doctors ourselves and nothing else. So, in the last 40 minutes or so, I have covered various parts of, or rather, some of the concepts which dictate the practice of perioperative nutritional therapies and nutritional practices. To summarize these, perioperative nutrition is an important determinant of outcomes in surgical patients.